So I'm throwing in a curveball because in staying on topic with this course, Emerging Technologies in Orthopedic and Musculoskeletal Care, I think dry needling is probably one of the biggest topics in physical therapy, and since I'm a physical therapist, I decided to present on dry needling. Quick question, how many of you have heard of it, been dry needled, or have had patients dry needled? Good, see? All right, so hopefully by the end of my 10 minutes here, you'll understand what it is, what it's indicated for, and whether or not it works. So dry needling is defined in the literature as a technique that introduces a monofilament needle into the skin, penetrating the underlying muscle and fascia, to effect change, to cause a mechanical disruption to the tissue. That's a picture of a hip, a bruised hip, with needles to help stimulate blood flow and promote healing. And there's the picture of the monofilament needles that we use in our practice. They can go from anywhere from 1/2 inch to 4 inches deep, or long rather, and indicated for different body parts. So sometimes I find myself, the best way to define it in practice to my patients is by saying what it's not. So it's not wet needling. We're not injecting anything. We're not taking anything out. They're monofilament, so there's no avenue to withdraw anything or inject anything. It's not an acupuncture-based needling paradigm. We aren't following meridians, and we're not affecting energy. We're using our basic Western medicine-based anatomical maps to pinpoint where we should needle. And we're not using ultrasound guidance, because physiatrists use dry needling as well, but they use it under ultrasound guidance, and unfortunately we do not. We're just basing it on our anatomy. So the indications, dry needling has been shown to reduce pain and improve tone or reduce tone in myofascial trigger points. Myofascial trigger points, you've all seen them and felt them probably in your practice, but they're defined clinically as taut bands in our musculotendinous tissue, where we see lack of blood flow, lack of oxygen, inflammatory markers, and even some neurogenic inflammation. And when you press on it, you can find predictable pain patterns. Needling, evidence has shown that needling in or around myofascial trigger points help to actually improve blood flow to the area and introduces nitrous oxide and oxygen, which are vasodilators. You get potential twitch response, which is in clinical practice, when someone does get a twitch response, if you needle or even press into a trigger point, they do have this analgesic effect. And studies have also shown that dry needling in and around myofascial trigger points can actually have an analgesic effect at the brain, at the central nervous system. So indicated for musculotendinous tendinopathies, repeated peppering in dry needling in ultrasound guided research has been shown to improve blood flow and break up adhesions and actually improve the quality and health of the tendon that you're peppering. And now I'm just going to review some of the evidence of whether or not it works. And I just want to say overwhelmingly there is a lot of evidence to support that dry needling is effective in reducing pain and also in improving range of motion, improving mental state, and improving outcomes. Much like all of our physical therapy data, there's very low to moderate evidence that it's better than this or better than that. And for those of you who are physical therapists or practice in rehab, most of our data supports if you do this, that, and dry needling, then it will be just as effective as this or that, or more effective as this or that. So just wanted to a couple studies there that show that it is effective, and then we'll go through some specific studies. And this year in the JOSPT, there was a really good meta-analysis of dry needling compared to other physical therapy techniques specifically. And there's moderate evidence to support that dry needling is more effective than our typical techniques in reducing pain, up to 12 weeks in both cervical and neck pain, but not necessarily in improving functional outcomes. The other techniques, the other PT techniques included stretching, joint mobs, and therapeutic exercise. In another study in the JOSPT in 2013, they reviewed 12 studies looking at dry needling versus sham or other techniques in reducing pain immediately or at 4 weeks post. And other techniques included other injectables like lidocaine injections, Botox injections, non-local acupuncture, Therax stretching. So it was actually a pretty good review. And summary right there, wet needling was definitely better than dry needling, except when we dry needled and elicited a twitch response. Laser was slightly more effective at reducing pain than dry needling, but dry needling was better than general rehab in shoulder pain in stroke patients. So in another study in the JOSPT specific to greater trochanteric bursitis, or pain syndrome rather, Dry needling was shown to be just as effective as a cortisone injection in reducing pain and improving outcomes. And lastly, effectiveness of dry needling in multimodal therapy for patellofemoral pain, pain score and functional outcomes assessed at 15 days and 3 months post. And this is basically dry needling versus dry needling with the therapeutic program you would normally do. And both groups provided or experienced significant decrease in pain and improvement in functional outcomes. So we found no evidence to show that it doesn't work. And so usually what I tell my patients is, as a therapist practicing 15 years, I'm always looking for the newer, techniques that might be more effective and a more effective tool in our belt to help us with what we already know works, which is our exercise to address impairments, stretching modalities. And so far in my practice, I can tell you that I do find it's a nice adjunct in reducing pain and definitely improving outcomes for patients, especially dealing with chronic pain or chronic tendinopathies. And just a little bit about how it works in the clinic, in the practice. We try to obtain a consent form for, as far as concerns for infection control. We're using sterile acupuncture monofilament needles, so each needle is in its own sterile container. We're wearing gloves. We use sterile disposable gloves, we use sterile disposable gloves, we use regular latex-free gloves, sterile disposable needles, and then we dispose of them in sharps containers, and we abide by OSHA regulations. And basic precautions that they teach you in dry needling classes, because oftentimes patients come up and say, how do you know you're not needling my nerve? How do you know you're not needling a vein? Basically, you avoid needling anything blue because we don't want to needle a vein. We abide by certain depths, and we don't want to go more than 1 inch needle in and around the thoracic spine, and then we don't go any larger than a 2 inch needle in and around L1, L2 because we don't want to needle the kidneys. When you have someone lying on the table and they're rather large, female or male, and you think a 4 inch needle could never penetrate that deep, you'd be surprised how quick with a 2 inch needle you realize you're not even getting through some of the fat and fascia. So, you follow these precautions and guidelines, and then you use your best judgment. So this is a quick video of a procedure. So this is someone's left hip, and the needle there is going into the TFL, trying to get a local twitch response and a trigger point in the TFL. I believe that was a 3 inch needle. And the patient said he felt it. And I believe there was a little twitch response elicited at that point. But just to review some of whether or not we can even use it, 27 states have actually issued a statement saying that it is within the scope of PT practice. 5 states, including New York, our neighbor, have denied that it's within a physical therapist scope of practice, and most other states do not use prohibitive language. Connecticut is one of them. So they're pretty vague, but the APTA, my professional organization, recognizes it as within our scope of practice, and that's where some of those other states defer to the APTA on that. And then the Federation of State Boards of Physical Therapy, which is the organization that regulates our national licensure exams and competencies in physical therapy, did a large review and analysis back in 2015, and they wrote that 86% of the knowledge you need in order for physical therapists to do dry needling is provided in a standard DPT curriculum. 14% of the knowledge is attributed to the advanced courses and training that you can do in order to become certified or trained in dry needling. And most good dry needling courses are about 3 or 4 days long with options for advanced training. And some of the common questions are whether or not you can bill for it, and you can, and you'll get denied. So basically you either choose not to bill for it, or you can bill private pay. And then some of the take-home messages here is that dry needling is effective in reducing pain, and it both associated with chronic myofascial pain, trigger point pain, but also tendinopathic pain. And I would love to see future studies in the field of physical therapy on dry needling affecting tendinopathies, because again, we're not ultrasound guided, so whether or not we're actually getting into the tendon is not proven, but with consideration both for the local needling of those tendinopathies, but how it affects the central nervous system and the pain associated with chronic tendinosis. Thank you.